Welcome everybody. It's Tuesday, 5 p.m. Central Time, and the first Tuesday of the month is our AFib meeting time. I'm coming to you from DeBakey Heart and Vascular Center here at Houston Methodist Hospital on the Texas Medical Center campus, the largest medical center in the United States in Houston, Texas. I'll be introducing my guest in a few minutes, Tim Greer, who I think knows a little bit about cold weather. If you're complaining about cold weather, you've got nothing to complain about if Tim's around, because he lives in Anchorage, Alaska. Although I think Anchorage sometimes is not that cold. I was there in May, and we'll get into that, and it was very pleasant, very nice. First things first, if you have a question, please submit it as soon as you can so we can get to it before the end of the hour. If you're on your phone, 37607, text DeBakey and send us your question. If you're on a computer, go to pollev, that's POLLEV.com, enter DeBakey and ask your question. And we will answer all questions. All questions are valid, so don't hesitate. If you have any question at all, this is perfect time to at least get an opinion. And you can ask a question for me, or it can be for Tim Greer, or for both of us, doesn't matter. We have some questions that have come in already. I'd like to address those. So this hour, I'd like to take the questions. I want to show you a few pictures from the Alaska tour that I got from Sandy Schremeyer from this summer. And then we want to spend some time with Tim Greer because I think his journey will help you significantly, especially if you have atrial fibrillation and you're trying to decide what to do about it. So, oh, thanks. Yeah, I got a little cough, not bad. So let's start right in with a question. And the first question is, how long does inflammation last after the Wolf procedure, and what are some of the issues inflammation causes? Well, as it turns out, anytime you injure yourself, you break a bone, you have a cut on your arm, anything, inflammatory cells rush to that area. Some of them fight off bacteria, some of them cause some swelling, and it's the beginning of the healing process. But it's very different than what you might think. The peak inflammation occurs at 21 days. And it doesn't go straight up and down, it's a kind of a long bell curve. So even 3 weeks after a broken bone or a cut, that's when inflammation peaks. It's the same with any surgery. It's the same with the Wolf procedure. Inflammation peaks at 21 days. Now, inflammation in and of itself can cause irritation of the heart and the heart sac and can lead to atrial arrhythmias. So the reason that we try to tamp down the inflammation a little bit is to make the heart a little happier and decrease the chance of atrial arrhythmias after the procedure, immediately after the procedure, during this inflammatory phase. We use steroids right after the procedure. We use colchicine, which is an old gout drug, very safe. We use that for about 6 weeks, and that works pretty darn well. It's not 100%. We still get a few people each year that get an inflammatory response inside the heart sac, which is called the pericardium. All mammals have a heart sac surrounding their heart. It's a protective sac. Whether you're a squirrel or a rabbit or a human, you have a sac around your heart. That sac has to be opened for any type of heart procedure on the outside of the heart, any type of heart surgery. So it is prone to inflammation if it's open, and that's why we use these techniques to decrease the inflammation. Now in the long run it settles down, but it can cause what's called a pericarditis, and that's when the inflammation gets pretty intense and angry, and sometimes we have to treat that with an extra round of steroids to settle everything down. Can clamping the left atrial appendage contribute to increased pressure in the left atrium, potentially causing or worsening left atrial dilatation? That's what was thought. And I was on the podium of a national meeting with Mark Lemaire, who's a heart surgeon in Europe, in Maastricht, and he felt that way, and he was concerned about closing the left atrial appendage. But so he did a study where he put a small catheter inside the left atrium, and then he closed the appendage. And what he found was that the pressure in the left atrium went up a little bit for 10 minutes, and then it was back to wherever it was. And he proved that closing the left atrial appendage has nothing to do with increased pressure in the left atrium. If you go back far enough in literature, you will see that documented. But I think Mark did a very good job of dispelling that myth. I personally have closed over 3,000 appendages. Did 2 more today. And the only thing that happens is the patients don't have to take blood thinners, and it helps them stay in rhythm. So there's no downside to closing the appendage. Another advantage of closing the appendage is the appendage can be part of the AFib circuit. So getting that out of the circuit helps. There have been many patients where I've taken care of them. They've had AFib and ablations, and they come to me, and the minute I close the appendage, their heart goes into rhythm. So it can participate in this arrhythmia. We're talking about the left atrial appendage, so it's good to close it. And lastly, it's been shown by several investigators that closing the left atrial appendage tends to decrease the blood pressure a little bit. There have been many patients that were on blood pressure medicines, and after the Wolf procedure and closure of the appendage, they no longer need the blood pressure medicines. There's some pressure sensors in the appendage, and they tend to make you hold on to fluid, and also has to do with your kidneys. And by closing the appendage, you can decrease your blood pressure. Not everybody, but some people can. It's been shown in some studies as well. Now, how about the Watchman? Will the Watchman decrease your blood pressure? It will not. And one of the studies was done with Watchman versus closing the appendage completely. The people who had their appendage closed completely had a decrease in blood pressure. The people that had the Watchman device had no decrease in blood pressure. And it makes sense because the Watchman's more like putting a cork in a bottle. It's putting a cork in the orifice of the appendage from the left atrium. So it's really not, it's closing it off, but it doesn't change the pressure in the appendage. In fact, one of the patients that we took care of today from St. Louis had a Watchman device. The left atrial appendage was still active. I ablated it with the pen, so it was no longer electrically active. But it's like a rock. When you push on it when you see it inside the heart sac, it looks like a rock. Not ideal. And it still leaked a little bit too. He had it done a few years ago. How long after the procedure should you wait before taking a vacation? Does the altitude matter? We have patients go to Europe within 3 to 4 weeks after this procedure, go on cruises. Over half the patients I take care of are out of state, and they fly in. And everybody's been able to fly out a week later. Even as far as the Philippines, which is about halfway around the world, and also a patient last couple years from Australia. They fly back after a week, no problem. So altitude is fine. In fact, you may find you do better, especially if you weren't in rhythm before the procedure, and the heart is in rhythm after the procedure. Do some people stay on a low-dose beta blocker and/or flecainide after tapering off amiodarone and the Wolf procedure? The answer is yes, but these are special circumstances. From time to time, we have someone that's maybe been in rhythm after the procedure for an extended period of time, could be 2 years, 3 years, 4 years, 10 years, and something gets them out of rhythm. The most common thing was COVID, frankly. I had patients that were in rhythm for 14, 15 years after the procedure, and a week after they got COVID or even the COVID vaccine, they went out of rhythm. In those circumstances, flecainide works very well. Flecainide is much better tolerated than amiodarone. It's twice a day. You can start out with a small dose, and that will keep some people in rhythm. So that's what the answer is for flecainide. So yes, on certain circumstances, we use it, but not normally. Normally, we just wean the amiodarone and that's it. If you're allergic to colchicine, is there an alternative med to use for inflammation? Well, it turns out there is, and it's Motrin. Motrin is very good at decreasing inflammation in your body. That's why it's so popular. And in fact, in many cases, if you're having pain in a joint, you might try Motrin because it does decrease the inflammation. Now, you do have to be careful about stomach irritation, gastric irritation with Motrin. So you might want to take it, not take it on an empty stomach, or some people recommend an antacid. So the answer to that is, yeah, Motrin's a good alternative. So we've got room for more questions. I'd like to review a little bit about Alaska before I put Tim on. There were some of you who organized a cruise, Alaskan cruise. These are all people that came here to Houston Methodist and had the Wolf procedure and decided to get together for a cruise. I was fortunate enough to join everybody when they were in Juneau. And of course, this wouldn't have happened without Sandy. And Mr. Producer, if we could show a picture of Sandy Schremeyer, who really has held the Facebook group together. For those of you who are relatively new to this, Sandy, when Sandy looked at the Facebook, I think it had about 10 people on it. The Facebook site was started by my daughter, I think before she got into medical school, when she was an undergraduate. And Sandy became the administrator, and now it's got something like 4.2 or 4.3K people on it. How she keeps it all straight, I have no idea. But she's pretty much single-handedly responsible for making that Facebook site available to people, and she's helped many, many people. She's probably helped more people than I have. So this, the tour was a cruise in Alaska, but it had a little side tour to go on a smaller boat up close to some glaciers near Juneau. And I joined people on that. And then after that little side adventure, we rented out a restaurant in the great metropolis of Juneau. Now I know how big Juneau is. It's not big. I think it's got about 20,000 inhabitants, but it's a very nice little city. And I was informed of a trivia question: what two state capitals can't you drive to? And they're Juneau and Honolulu. And pretty much the only way to get to Juneau is either fly in or be on a boat. But we'll ask Tim about that in a minute. So we rented out a restaurant. I got a few pictures to show you. Mr. Producers, if you go to the next picture, we'll share that with you. These are some pictures of some of the participants on the Alaskan cruise, and you'll recognize yourselves on here from all over the country, from people that had, some had had the surgery several years before the cruise. And another picture now. And we rented out a nice little restaurant in Juneau, and I thought it'd be nice to do a few magic tricks as well. So we did a little magic and had a really fun dinner. And the next picture, please. Here's a group shot of us in the restaurant. And there might be one more picture, I'm not sure. Let's see. That's the last one? Okay, good. So for all of you that attended the cruise, it was great. I really enjoyed it. It was a lot of fun. Thank you for including me. And for all of you there, thank you for putting your trust in me and in Houston Methodist to help you out with your atrial fibrillation. With that, Tim's been patiently waiting in the sidelines here. I asked him where he is today. He's in Anchorage, Alaska. He has a story, his own story to tell you about atrial fibrillation. And while he's talking, if you have a question for me or for Tim, again, Mr. Producer, show that up there for a second. Either get on your phone and go to 37607, text to Bakey and ask your question. Or if you're on a regular type computer, go to pollev.com, enter DeBakey, and then respond to the activity. Tim Greer was kind enough to join us today, tell us about his journey. Tim, thanks so much for being with us, and welcome to the show.
Yeah, thank you, Dr. Wolf, for the invite. And yeah, what a journey it's been for me. So I'm 58 years old. I live up in Anchorage, Alaska, and I first discovered this problem in 2019. So how it all started was on a moose hunt. My buddies are across the inlet to the south, and they're on the lake, and they get a moose, come into camp, at night, and they knock it down. So I get a text message, and I'm like, holy cow, right on, I'll be over there in the morning, help you pack it out. So this is September 2019. I fly over there, land, yep, they got the moose down. I go, and historically, no problem, just throw a hindquarter. It's a short walk over my shoulder, carry it to the plane and help them pack the thing out. So I can't even do it, right? I go about 100 yards, and all of a sudden I'm breathing and I can't catch my breath. And I'm like, what the heck's going on? So I'm thinking maybe dehydration. I don't know. But both my friends now they're both doctors, and they're looking at me and just going, what's up with you, Tim? And I'm sweating like crazy, and I can't go, and I don't understand what's wrong with me. All right, so we go through this, but if I sat on a stump, I could catch my breath. Everything would come back. Hey, I felt good again. Odd. So fly home, we get, everything put away that day. And then the next day, they start texting me and calling me and saying, hey, we never seen you that week before. Something's up. You need to go to a doctor. So by Friday that week, I go ahead and I have a doctor, but I hadn't been there for over 8 years and at this time I'm 50 years old, and I've never had a physical problem before, or a medical problem like that. And I go up to the front desk, and they're like, hey, we don't have any record of you being here. You're not a patient, and McNitch isn't taking new patients. So what? So I go down to the parking lot, texting them, my other doctor buddies, and they just said, hey, call him on his cell phone. So I did. Even though it was his day off, he just happened to be in his office. So he goes, no, come on up here. Sorry about that. We had our system redone and just got rid of, records. Anyways, he's looking at me, and I'm telling him kind of what's up. And then he grabs his stethoscope and sticks it on my chest, and he looks at me, and he's like, hey, would you mind taking an EKG? And I was like, what? What's up with my heart? He goes, yeah, let's just get on the EKG. So, we get on there. Yep, I got AFib. So a cardiologist is on staff part-time. He, UW medicine guy. And I'm like, okay, let's meet with him next Monday. And he whips out a flow chart, and there's all these paths to go by. It's all new to me, so I'm learning everything. And man, I learned a lot. But the path that I knew of and heard of, there was also a bush pilot, Doc Compton, here in Anchorage that performed catheter ablations. And I was like, well, that's probably the path I'm on. I heard that's a good way. But first, let's do a cardio version. So, yeah, we get cardioverted. Bam, it sticks for like a week and a half. I'm back in AFib. So then we go on the path to the catheter ablation. I get that. Of course, now I got to back up. I got put on blood thinners right there, sample packs when I first went into the, the hospital. And yeah, expensive. Holy cow, whatever. But so I'm taking Eliquis twice a day. And get a catheter ablation the beginning of 20. So let's call this January of 20. It sticks for about 8 months. And then I flip back into AFib. They want to wait a year. So the next January, I get a second catheter ablation. It lasts about 3 months, multiple cardio versions. I don't even know how many. I think Dr. Wolf and I were talking about at least 7 of them, 2 cardio versions. I'm going back and so now the electrophysicians, I don't want to do another catheter ablation. You need to go up and see the thoracic surgeons and get this other procedure. And I don't know the name of it, but basically get the back wall of my heart. And so I went up and I see this.
Let me interject just for a second right there, Tim. I think they were interested in doing the convergent procedure, which is where the surgeon goes in below the breastbone and goes up and just burns the heck out of the back of the left atrium, the back wall.
That's probably it. But the thoracic surgeon said, I don't know he said, I would rather do open heart surgery on you and do a maze from the outside.
Okay.
And then that's what he recommended, not the electrophysician. I started sweating right there in my chair. I'm 52 years old, and I'm like, open heart surgery. And he's like, I go, what if I don't do anything? He said, hey, the meds will take you out. They're too young. He goes, it's rare that people with persistent AFib walk into my office like this. And I asked, is there somebody that can do it another way? And he said, well, there are people that can do arthroscopically, and I don't have the terminology right, but I don't know who they are, and I wouldn't trust them unless they've had over 2,500 under their belt, and they do 200 to 400 a year. And so he goes, come back and talk to me next week. So I get online and I find Dr. Wolf. And so I call him back next week, and I said, Dr. Wolf? He goes, I don't, but my partner might. And he didn't know this, but this is during COVID too, which made everything harder. But I could hear him in the background, and his partner says, oh yeah, Dr. Wolf, he's the best in the world. And I was like, oh, okay, right on. Well, what would you recommend? Yeah, go see him. So that went down there. Dr. Wolf took me on, and it was awesome. Had a heck of an experience. I flew in there. I think I was from flying in to leaving might have been around 14 days. I'm not absolutely positive on it, but something like that. And I got my life back. I got off the amiodarone, which was terrible for me, and the blood thinners, which was terrible too. And here I am, at 58 years old and in rhythm and have my power back. So it's been awesome.
That's a great story. If any of you have any questions for Tim, go ahead and enter them now. So Tim, you're back to all your usual activity?
Yeah. So the biggest one was flying bush planes. So I got 2 of them, and that's my life. I spent my whole life working. They're expensive. So got to the point where I could afford them, and then I lost that privilege because the FAA suspended my medical certificate and would not give me one. And I did get it back. Just in, I can't remember. I mean, basically a year after I got.
Well, there was several years ago. I went to Oklahoma City, the headquarters of the FAA, and I spent 2.5 days with those people. And after that, they said, well, we've seen a lot of pilots that have had catheter ablation, and we've seen pilots that have had your procedure, and the patients you've taken care of don't have AFib anymore. Now, in the end, they said, we're a government agency. We can't recommend one treatment over the other, but we can tell you that your patients do very well. Your pilots do very well. Now, I learned being up in Alaska this summer, you either pretty much got to have a boat or a plane to get around that state, right?
Yes, agreed. Oh yeah, and that, you know, have both. We like to fly to boats and then use boats, but yeah. So I got my FA medical back, and then, you know, just to add on to this, and so here's a question that I asked you when I first went down there. I said, how come the cardiologist that I first sat down with had a flow chart for all these paths for me to go, but none of them talked about a mini maze?
Yeah. Okay. Well, that's a very good question, and one that I'm asked quite often. Generally, cardiologists and electrophysiologists give you the options that they do. And if they don't do it, you don't need it. So I think from an ethical standpoint, it would be much better if they would at least mention to the patient what all the options are, whether or not they do that option, whether or not they recommend it. Okay, they can say, we don't recommend the Wolf procedure. Okay, I'm all right with that. But at least then the patient can do their homework and decide on their own. But you're right, most of them just don't even mention it. And I hear lots of stories from patients like, well, I mentioned your name, and the cardiologist said, well, if you want open heart surgery, go ahead. But as you know, it's not open heart surgery. It's a minimally invasive procedure. We don't stop the heart. We don't use the heart-lung machine. We don't use blood thinners. And you're awake at the end of the procedure.
And to add to it, I just used ibuprofen and Tylenol for my recovery. I never did need any of the other narcotics, so that was awesome.
Yeah, it's well tolerated, and nothing's 100% with AFib. I want everybody to understand that nothing's 100%, but I'm confident that what we do is 100% better than a catheter ablation. And you're living proof. You had 2 of them, and it really didn't help you that much. And then when you came here, you got rid of it. Now, if you would have cancer in any hospital in the United States and were treated and went 5 years without a recurrence, you would be deemed cured, right? That's what they do with cancer. You go 5 years without a recurrence, you're cured. But they don't do that with AFib. They say, well, no, that's not enough. That's not enough. You're never cured. What I can tell the audience today is we have patients that are 23 years out, because that's when I started doing the procedure, who are still AFib free, and I still follow some of them, so I know that for a fact. We are doing a retrospective study now. Marcel, my fellow from Europe, who's looking at all the data, at what are our rates of AFib after the procedure, and he's interrogated over 500 links. This is the loop monitor that we put under the skin that allows us to monitor an EKG every day for 5 years. It was 3 years when you were doing it, now it's 5 years. We're looking at over 500 patients to see what the reduction in AFib burden is with the Wolf procedure, all comers, people like you that have had previous catheter ablations and people that haven't. Now, back then, I'd say 60%, 70% of the patients I was seeing during the pandemic had failed ablations. That's down to 50% because many more patients now are looking at their options and they're saying, I want a one and done. I don't want to go the 2, 3, 4 ablations and then decide to go another route. And I think that will give a better result overall. And I say that because catheter ablation scars the inside of the heart. It kills cells. It kills your heart cells. That's how it works. But I believe that AFib is caused by the nerves, which are on the outside of the heart. these nerves are not affected by catheter ablation, so the substrate for AFib is still there. And that's one of the reasons I think catheter ablation doesn't work. It's technically almost impossible to get the nerves from the inside of the heart. From the outside of the heart, they're right there. Pretty simple. I won't say it's easy, but it's pretty simple. Now, this takes us into another area, and we have some questions. I'll get to them, but if you have anybody else have questions, get them on now, because we're at the bottom of the hour right now. Catheter ablation was mainly radio frequency or heat, creating heat that burns the inside of the heart. What are the issues? Well, in my opinion, it doesn't get the nerves. If you are out of rhythm continuously like you were, the chances of staying in rhythm with a catheter ablation is about 40 chances out of 100. 35 to 40 chances out of 100 at 1 year. That's it. Not very good. If you take a blood thinner, the chances that decreases your risk of stroke is pretty well known. It decreases your risk of stroke by 60%. 60% is not that great. A lot of people who take a blood thinner think they're 100% protected from a stroke by taking the blood thinner. You're not. If the appendage is closed, and that's what Tim had done, that decreases your chance of stroke by 97%, and you don't have to take blood thinners, which have side effects and are expensive. And if you're a guy out in the wilderness or on your plane, you probably don't want to be on a blood thinner. Well, you probably don't want to be on a blood thinner anyway, but especially if you're an active guy outdoors or a gal or involved in sports. But it can even be just falling down, or I've had people come back to me because they were on blood thinners and they fell off a ladder, hit their head, had to have emergency brain surgery for bleeding, and they come to me and say, I can't take blood thinners anymore, I just can't do this. The newer, then after catheter ablation with heat, came freezing, cryoablation. Well, we'll freeze the tissue and then that'll take care of it. That came and went. Now the latest flavor is called pulse field ablation. It's a different way. It still kills the cells, your heart cells on the inside of the heart, but it does it through a different mechanism. It doesn't heat it up, but it opens up the pores in the cells. In fact, another name for it is electroporation. So we all have pores. We're made up of cells, and all our cells have cell walls. And fluid goes in and out, and it's highly regulated by channels that have potassium and calcium and so forth. Well, what pulse field ablation does, it creates a very millisecond pulse that opens up these pores, and fluid pours into your cell, and the cell ruptures, causes cell death. So it's a different mechanism, but it still kills heart cells. Now, they're very proud to say that this doesn't affect the nerves. I got a problem with that, because I believe that you've got to affect the nerves if you want to get rid of AFib. And these are the autonomic nerves that go to your heart and tell your heart to speed up when you're in danger. But it tells your heart to speed up when you're watching a scary movie. Why should your heart speed up? You're sitting in a chair watching a movie. It tells your heart to speed up when you look over the edge of a tall building and you get sweaty hands and your heart rate goes up. It's these autonomic nerves that get out of balance that cause the AFib. So a therapy that touts the fact that it doesn't affect the nerves may not in the long run be that good. Now, the other issue with catheter ablation is every time an ablation is done, it creates little bits of dead tissue that gets pushed into your brain. With regular catheter ablation, testing the arteries here, we find 2,000 to 4,000 little pieces of stuff going into the brain every ablation. Now, the most common symptom, I believe, is a headache. And I think that headache is because you got little pieces of crud going into your brain. We tried it with the Wolf procedure, same thing. put the clamps on, check for little pieces of stuff going into brain. Zero. Didn't occur. Because we use a clamp. When we close the clamp, we're only doing a burn like a line, like a pencil line, and there's no blood circulating there. So you don't get what's called emboli from the procedure. It's still too soon to say if pulse field ablation is going to be the end all. I don't think it will. The patient I did today, it had one RF ablation and one pulse field ablation. So I'm already starting to see people that have failed pulse field. And in the first study that looked at radiofrequency or heating the heart for ablation versus the new way, rupturing the cells, at midterm results, there was no advantage of the pulse field ablation as far as being AFib free. The pulse field was safer and faster, but it wasn't better. So I can imagine electrophysiologists want to switch to pulse field. Safer and faster. But efficacy, which means what percent of patients are free of AFib, currently doesn't look any different. But it's still going to be recommended. Let's take a couple questions. I had the Wolf procedure in June 2024. I'm doing fantastic. Thanks again. Now, my wife had her very first AFib episode last week. It lasted 90 minutes, resolved on its own, nothing since. What should be her next step? Well, there are situations where you may have an episode of AFib once a year for an hour and a half, and you don't need to do anything. If you really want to take a very objective look at it, have an implantable loop recorder placed. It's a local procedure. I put in 2 today. With the procedures, I put in probably 4 or 5 a week. It gives an EKG every day to your physician for 5 years. The one I use is a Medtronic one called the Link, L-I-N-Q. It will tell you very clearly how much AFib you have, and it calculates your AFib burden per month. So if the AFib burden is very low, you're having very few episodes, maybe you don't need anything. If you're just having a few, maybe flecainide will work just fine. If it's a higher burden, or it starts occurring more often, then maybe a catheter ablation or a Wolf procedure would be the way to go, but it's way too early to say. I would look at it objectively and wait several months and see which way it's going. Also, simply a beta blocker. If she's not on a beta blocker, these are blood pressure medicines that have been around for 50 years. A small dose of beta blocker a day can prevent the AFib from occurring. Now, here's a little caveat. You should take the beta blocker once a day for 6 to 8 weeks before you make a decision whether it's helping or not. Because you take a very low dose, 25 milligrams or even 12.5 milligrams a day. Give it 6 to 8 weeks. Don't just take it for a couple days and say it didn't work. Take it every day for 6 to 8 weeks and see if that helps decrease the AFib or keeps it from recurring. Why do lots of people get AFib when sleeping or lying down but don't have sleep apnea? I don't know the answer, but I do know this. You are much more aware of your heart's rhythm when you're lying down. And I believe it's because your brain isn't distracted with all the other stuff we do every day, flying or running your boat or doing your job. You're kind of busy and you may be out of rhythm and not even know it. But in the evening when you lie down and the external stimuli have decreased, that's when you're much more aware of your cardiac rhythm. I see Tim smiling. Does that make sense, Tim?
Yeah, absolutely. I mean, that's how I.
Did you experience? Were you more aware of it at night?
Oh yeah, even today. So I have people that, to me, I can tell if I'm in rhythm. Just by focusing, I can feel my heartbeat now because of everything I've been through. It's maybe extra sensitive to it, but at night sometimes it's beating so nice, and and calm, but I like to listen to it because it feels good. It keeps me up for a little bit. But yeah, I can tell laying down at night exactly what my heart's doing.
Here's a question for you, Tim. Tim, you've had a lot of cardioversions. Did you ever resolve back to normal sinus rhythm naturally? In other words, without a cardioversion?
No, and I never did. That was another unique thing. Once I went into AFib, I just stayed in AFib the whole time. But every cardioversion I had, it only took one press of the button and I was back in rhythm. Probably the quickest I went back out of rhythm was 48 hours, and the longest was probably 3 weeks.
Okay. My BMI, that's body mass index, is 37, so I'm considering a pulse field ablation, and my GLP, I can't read that, to reduce my BMI to an acceptable level. I'm hoping this ablation keeps me out of persistent. Well, here's another option for you to consider. What we're getting at here is I've asked people who are morbidly obese to get their weight down to a BMI of about 31. There are two reasons for this. One is doing the procedure, the technical part of the procedure gets pretty tricky when you're really large. When I invented these instruments and made them in the lab, they come in one size. And it's pushing the limit of some of the instruments when your BMI is 37. Now, it depends on whether your weight is all in your belly or all over in your chest, but still, it's technically more challenging when the BMI is above 31. Makes a big difference. And secondly, for recovery, for patients who've lost weight, their recovery is so much easier if they're of a normal body mass index. So what can you do in the meantime? Well, what I do is I ask patients to take low-dose amio. Low-dose amio is pretty well tolerated, maybe 100 a day. Not a loading dose, not 800 a day. That's where you get in trouble. And there's a prior webcast that we've done here at DeBakey along with Dr. Fahed, where we both were on the webcast. We talked about amiodarone. If you keep it low dose, it's pretty well tolerated. So take 100 a day for 8 weeks, and after that, it'll protect you from the AFib episodes while you're losing weight, and then lose the weight and you could have a Wolf procedure. I think it's always harder to get in rhythm with the Wolf procedure if you've had previous ablations. You can still do it. Tim's a living proof of it, but it's a little bit more difficult. So I wouldn't temporize with a pulse field ablation. I would temporize with low-dose amiodarone. And if you're not in rhythm in 7 or 8 weeks, get a cardioversion. And one of the patients I did today did that. He was overweight. He's lost 35 pounds over a year, but he was out of rhythm all the time. Started the amiodarone over a year ago, low dose, had a cardioversion, and he's been in rhythm the last year. Why? He lost weight. Now he's still on amio, so we do the procedure to get him off the amio and allow him to get off blood thinners, but that worked fine. He stayed in rhythm while he lost weight on low-dose amio. Once I get my BMI where it should be, then I would be able to pursue getting the Wolf procedure. Absolutely. Absolutely. We've had a lot of people do that. We've had people lose 70, 80 pounds. And when they come to Houston, they fly into Houston, they say, "Thank God, Doc, I feel so much better already, even before the procedure." And they do so well after the procedure. Does having a severely enlarged left atrial size, left atrial volume index, 49 milliliters per meter square, cause concern for you to do your procedure? Well, we know this. We know that once the left atrium is over 200 milliliters in size, the chances of staying in rhythm start to go down. It doesn't just drop off a cliff, but it does go down a little bit. And generally what I look at is how big is the left atrium and how long has the patient been out of rhythm, continuously out of rhythm. If you've been in and out for years, That's not what I'm talking about. How long has the patient been out of rhythm continuously? And I have a rule of 5. If the patient's been out of rhythm continuously for 5 years, more than 5 years, and the left atrium is greater than 5.5 centimeters, which can be around 200 milliliters, then we have to have a discussion and think about it. But we have many patients. One who comes to mind is a medical rep for Medtronic, and he was out of rhythm for 8 years, had a left atrium greater than 200 milliliters. He's been in rhythm for 4 years since the Wolf procedure. But I told him your chances of staying in rhythm aren't maybe as good as what Tim's were, but still reasonable. So that's a discussion that I have to have individually with each person. And you can always get a consult with us. We do videos. You don't have to come to Houston. It's a Zoom call. All you have to do is call 713-441-9342 and get an appointment. Or go to the Wolf Procedure website. Just put in Wolf Procedure and go to that site. Or you can go to the Facebook site, which is, it's Wolf Procedure and Live AFib Free. But go to the Wolf Procedure, and I'm happy to see you. The good news is that we are pretty much caught up. We were about 9 or 10 months behind with a waiting list, and we were very diligent in 2025. We're caught up to about a month or so. If you're thinking about this, you want to get a consult, you can get it right away, and you won't wait 9 months to get the procedure if you decide and we decide that you're a good candidate. Tim, any closing words for the audience? First of all, you were great. Thanks for giving us a really clear synopsis of your journey. What say you?
Yeah, no, thanks for having me here. It's always fun to listen to you, and I learned a lot. And what's funny is just today, friend of a friend's got a heart deal, and he's like, "Hey, Tim, send me the information." So I sent him a link to your site and told him what I had done. So all I can say is that hopefully, you got somebody that you're training up to follow in your path.
We're trying. What's the weather like?
Hey, it was, we got a ton of snow recently, and now it warmed up. It's icy out. It actually was raining a little bit about an hour ago. So we're hovering right around 33 degrees or so. This time of year it gets good though. It's from basically February 15th on, the sun starts coming out, and it's really cool if you can get out, in the mountains above tree line. It's awesome. And the snowpack.
You were kind enough to say you would share one of your emails with our audience. So, Mr. Producer, if you could put that up for everybody. And thank you. And explain to us what RM Consult is. What do you do?
Well, I'm a civil engineer. I head up our engineering department, and the name of our firm is, we're locally owned as an S corporation. And the name of our firm is R&M Consultants Inc. And we provide engineering services, as from geotech, environmental, permitting, surveying, and civil engineering disciplines.
That's great. Well, you did a fantastic job. Thanks for joining us today. Continue having a good life, AFib free. And ladies and gentlemen, if you have a question for Tim, feel free to give him an email shout out. I believe we'll be doing this again next month, first Tuesday of the month, 5 p.m. And we'll have another arrhythmia adventure. Thanks for listening in, everybody. We'll see you next month. Thanks a lot, Tim.
Yep. Thank you. Goodbye.
Bye-bye. Bye, everybody.